Dear colleagues, my name is Joep Perk. I'm a senior professor of health sciences from Sweden. We're going to talk about prevention. Is that an issue for the general cardiologist? And in this talk, I've taken two real experts from the field. First, Professor Ian Graham from Dublin with a long track record in risk assessment. And second, but not last, Professor Guy de Bakker from Ghent, Belgium, is one with a great interest in preventive cardiology. Guy, let me start off asking you, what is cardiovascular prevention and why is it needed at all?
Well, we need, in the asymptomatic, apparently healthy population, we need to stratify that population in different subgroups in order to intensify our preventive action in function of the total cardiovascular risk. So we have to assess total cardiovascular risk in these people in order to apply the most correct action of prevention.
But why should we do this? And isn't it sufficient that we doctors become good in treating patients? Why doing this extra work?
Well, prevention is so important, you know. The burden of cardiovascular disease is immense. The majority of new events comes from that large group of apparently healthy people. In them, we have to prevent the first event, and for doing that, we have to assess their total cardiovascular risk.
Do you feel that we are actually doing this in practice?
Well, that's a big question there, that we do not apply sufficiently what we are recommending in our guidelines.
Well, let me ask Ian, you have been working a lot on tools for assessing cardiovascular risk. What are these tools all about?
Well, we know that clinical judgment isn't terribly reliable. Therefore, we have various scoring systems. The European one happens to be called SCORE. It's a simple chart or an electronic version. But we have a challenge. It's not so much to be clever, it's to communicate better with our patients. And that's really been our challenge. And one of those challenges is a young person with lots of risk factors, and yet their risk score seems to be quite low. And as they get older, of course, it will become very high. And we're trying to work out how better to communicate this simple problem, what to do about it. There are several approaches. One is relative risk, so your risk is only 3%, but it's 10 times higher than it should be. The other is risk age, that if your risk age is, although you might be only 40, is actually 60, because that's the age of somebody who doesn't have any risk factors.
You mean your vessel's already 80 while you're still 40?
So if you want to go back to being 40, you do something about your risk. And the other one is lifetime risk. What is your total risk over a period of time? But the easiest ones, I think, are relative risk, and risk age.
Okay. What I feel when I talk to my patients, when I start to talk about risks of dying, patients start to think about something else. Do you think we convey the right message? What would it be if we would change it around and tell people you have a fantastic option to remain healthy? How would you see about that?
Yeah, I mean, that's the whole trouble, is turning healthy people into patients.
Yes.
So what we need to say to them is, actually, you're perfectly well, but I'd like to make sure you're still perfectly well in 20 years' time. And we can help with that by looking after your risk.
A question to Guy, just before rounding up. In what way could we reach out to general practitioners especially? How could we get the average general practitioner in Belgium, for instance, to actually apply risk assessment and actually convey the message to the patient in a proper way? Is there any hope for that?
Well, there are different issues there. First of all, we have to continuously educate our clinicians in general and the GPs in particular on this issue. Then we have to give them sufficient time, I think, to discuss that in a proper way with the patients, and that is one of the major issues that our GPs in my country tell us. Okay, we have, for each consultation, we have 7 minutes. That's it, for everything. And that is not enough. We need to communicate with your patient sufficiently on such an important issue.
Thank you. There's an old Chinese saying that the inferior doctors treat the patients, the best doctors prevent the disease. Do I suppose you agree with me there?
That is
absolutely
very important.
It has been a pleasure to talk to superior doctors, and by rounding this up, assessing cardiovascular risk and conveying especially the message to patients will give patients a tool to work on their own health. And we know by taking responsibility for your own health, you can actually influence that. Thank you very much.